Hi, everyone, and thank you for choosing to attend our talk this afternoon. My name is Allison Young, and my teammate is Anna Berman. We are here today to tell you about our work with RTI International. Specifically, we hope to share what we have learned through exploring interventions for the opioid crisis here in Durham. It's common knowledge that our country faces a serious problem with the misuse of opioid medications. This epidemic has led to very serious consequences. In North Carolina, we have had a six-fold increase in the number of medication and drug poisoning deaths in the past 20 years. But while we know the opioid crisis is global, communities and populations are unique. Our work aims to take what we know about Durham and model the potential impact of interventions that are unique to our community. We developed three primary research questions to guide our capstone project. We want to know first, who are we talking about and how are they dying? Second, we want to understand a bit about these people's lives and how they end up using, misusing, and overdosing from opioids. With this information, we can explore and isolate factors unique to Durham County and look at the role existing and potential interventions may play in preventing deaths, as this is our ultimate goal, to prevent deaths. From our capstone work, we have demonstrated a way to intelligently combine different data sources and use that data to model individual and population outcomes. We hope that this proof of concept will provide a springboard for future work and resources for RTI and the State Department of Health and Human Services. Ultimately, we hope that any interventions that are recommended through these individuals and agencies can help save lives. Our first step was to understand who dies from the opioid crisis. To do this, we analyzed and mapped mortality data for Durham to understand descriptive statistics of our target population. We learned that in Durham, opioid deaths disproportionately affect middle-aged white men and is both an urban and a rural problem. 80% of drug overdose deaths from 2004 to 2014 fell between the ages of 31 and 60. 63% of those who died were white. It's important to note that opioids are not the only drug of concern in Durham, as cocaine deaths are also seeing an increase in numbers, particularly in the African American community. In future work, we encourage RTI and others to incorporate multiple drugs into their modeling and research. But for our purposes, we have focused on opioid and heroin deaths.
So taking this one step further, we wanted to see if we could predict opioid users and misusers in Durham County. To do this, we used geographic and demographic data from RTI's synthetic populations, as well as the National Survey for Drug Use and Health, to predict households with instances of opioid misuse. On the left here, you can see a map of where we've identified potential opioid misusers. You can make out the highways, and you can also see some similarities between this map and the previous map of actual deaths in Durham. All that said, our performance of our predictions was actually rather poor. We were only performing slightly better than chance. But this isn't all that surprising, given that we're only using a few demographic variables to predict a really complicated behavior, such as opioid misuse. What this tells us is that our map is mostly based on population density more than anything else, and that we need more information to generate better predictions. So moving on to how can we model the lives of a unique community of pain patients? So to do this, we used a conceptual model from RTI, and this is essentially a Markov chain with various states and probabilities associated with moving between each of these states. So in this model, a pain patient can be prescribed opioids, they can become non-compliant with these drugs, they can go into treatment, they can die, they can become a heroin user, and they can also interact with different treatments. And all of these create a really complex web of relationships and interactions. So in order to simulate a community, we use something called agent-based modeling. And this essentially simulates a community of agents, or in our case, pain patients, each of which are moving through their own version of that Markov chain. This agent can also interact with other agents or entities such as dealers or pharmacies. And the model simulates the life of a community for 5 years. And at the end of that simulation, we can look at outcome metrics, such as the number of people who died from opioids, the number of heroin users, the number of non-compliant patients. We're also able to tweak starting parameters to apply different interventions to our model and explore how these interventions affect outcomes. In terms of the agent-based model that we used for this project, there are so many small interactions or relationships, but at a super high level, this is the day in the life of a pain patient. That pain patient is looking to take opioids, and they seek those opioids before taking them. After they take them, they can either overdose or not overdose, and then kind of start this process all over again. And our agent-based model is essentially doing this process every day for 5 years.
We used a three-step approach in tailoring RTI's existing agent-based model to a Durham population. First, we performed a literature review to see what kind of local outcome data are consistently available at the county level. Next, we added additional variables to the model to reflect local policy. And finally, we calibrated the adapted model to obtain expected outcomes. While the amount and types of data resources are expanding related to this topic, few resources were available during the full 5-year span we aim to model. These measures of prescription drugs, for instance, were first collected and shared publicly in 2017 when North Carolina launched the Opioid Action Plan. The new data serves as a baseline for the future, but historic data was harder to come by. This was one of several challenges we had in obtaining robust data points for model evaluation. Additionally, measures we have now are not always apples to apples with the measures we need for our agent-based model. For example, we may know about the number of OD reversal medications that are distributed. These are also known as naloxone, but not necessarily how available they are at the time of an overdose, which is the measure we use in our model. Therefore, we only have partial data. And so because of this, the primary data we relied on for our outcomes was mortality data. These data we found were complete and consistent. In the absence of other hard data, we used estimates from population studies to determine some expected outcomes from our model. To determine how many non-compliant drug users we expect to see in Durham, we took the number of known agents, such as the county population, and overlaid them with percentages from literature. From these estimates, we believe there are about 8,000 non-compliant drug users in Durham. This number in itself may be a useful outcome for our work, as it could be used in grant applications or in future modeling. We ultimately settled on the following outcome measures as evaluation metrics for our model. Over a 5-year period, we would expect to see 75 opioid deaths, 55 heroin deaths, and approximately 8,100 non-compliant patients. Once we had our outcome measures settled, we focused on local specific inputs for our model. These agents were used to set up the model in a way that accurately represents Durham. This includes entities that play a role in the daily lives of opioid users, such as physicians, pharmacies, and drug dealers, as illustrated by this table. And below the table, you can see how we put these agent measures into the NetLogo software to implement our model. Finally, we had to paint the picture of interventions in Durham and policies that would impact our outcomes. North Carolina launched the Opioid Action Plan in 2017, including restrictions on opioid prescribing and increased resources for treatment. But previous to this, we don't have a lot of existing data, so we relied heavily on the expertise of our client for this step and knowledge from the broader opioid research community.
Beyond updating previous values, our client was also interested in adding some values as well, and one example of this is buprenorphine treatment. This treatment is essentially a drug that blocks the effect of opioids, making taking opioids essentially pointless for those addicts who are in treatment and trying to stop taking opioids. We found some evidence that this treatment can be as effective as 30%, but we didn't find any really conclusive evidence about how often this is prescribed in Durham. But based on what we saw, we estimated it could be prescribed in approximately 1 in 5 patients who are seeking treatment. After exhausting our literature review, we wanted to essentially fill in any gaps in our predictions by tweaking other parameters in our model. So we tried so many different ways of doing this, but the most successful were increasing the probability of overdose based on an individual's drug supply at hand, increasing the added risk of heroin use over opioid use, and decreasing the risk of probability of a bad batch of heroin, or AKA a heroin batch laced with fentanyl, entering the community. After all of this, we were able to get consistent and really accurate predictive results for our Durham outcomes, which was really amazing, and it meant that we could move on to our third and final question. What can be done to prevent opioid deaths in Durham specifically? So we looked at 6 different interventions here: naloxone availability, PDMP compliance, emergency department initial dosages, buprenorphine treatment chance, average prescribing tendency, and average initial or emergency department prescribing tendency. So here's a chart of all of our results. It can be a bit overwhelming, but I think it does a really good job of explaining what we saw. So in each column, you can see a different intervention, and in each row, you can see a different outcome measure. So looking at the first column specifically, we see naloxone availability and its effects on opioid overdoses, heroin overdoses, opioid death rate, heroin death rate, and heroin users. So we can see here that actually a lot of the interventions didn't have a huge effect, but we saw that 2 interventions did have a meaningful effect that we dug a little bit into. So the first of that is naloxone availability. Like we said before, naloxone is a drug that can reverse an overdose that's already taken place. So as we would expect, we see that the number of opioid and heroin deaths are decreasing with increased naloxone availability. But interestingly, we also see that heroin overdoses and heroin users seem to increase. And we think that this is because if a heroin user is overdosing, takes naloxone, and doesn't die, that heroin user remains in the community. And so with increased naloxone availability, we have more heroin users and then more heroin overdoses as those users continue to use and continue to overdose. So I think this does a really good job of highlighting the effects of agent-based modeling and how it can really show those balances of outcomes. The second intervention that we saw having a meaningful effect was emergency department initial dose. So we saw that a dose of over 75 MME is associated with increased heroin overdoses and increased heroin death rate. And again, we're seeing that decreased heroin user. And we think this is because if an emergency department prescribes a higher initial dosage, then it's easier for patients to get addicted to that opioid and then turn to heroin at the end. So again, these are just indicative of places for future research. And we think that with the help of RTI and any grants, this research can be continued.
When we asked our client who could benefit the most from our work, he identified the State Department of Health and Human Services as a primary audience. Other audiences may include researchers who want to model their own communities and the broader RTI workforce. Therefore, we created a Prezi presentation to assist our client in communicating project findings. We chose Prezi because of its flexible design. For those who may be unfamiliar, Prezi is a web-based presentation tool similar to a slideshow, but rather than a linear mode of presentation, Prezi is hierarchical. This allows presenters and online viewers to dig as deep into a topic as they would like, or simply give a basic overview of the main topics. With this tool, our client can tailor his presentation appropriate to his audience, but also have all the materials on hand as needed for questions or discussion in a simple to navigate format. Prezi also offers the ability to record a video of the presentation, which we have created and shared with RTI to include in an internal RTI blog post. And with that, we will conclude the presentation part of our talk and open up for questions and discussion. Thank you so much.